Welcome back to the program, and thank you so much for your company this far. My name is Samuel Njoroge. You can engage with us. 20511 is our SMS line. Begin with the initials GMK. You can also hit me up on Twitter at Sami1 Njoroge is my handle, and you can also find me on Facebook. Samuel Njoroge is my user name. Need to have a conversation around tuberculosis in this country. Of course, that day will be marked this year on Thursday, March 24th?
Correct.
Yes, March 24th this year. The slogan is MULIKA TB, MALIZA TB. That is precisely what we'd like to do on GMK this morning. Tafadhali tusaidie kumulika TB na pamoja tutamaliza TB. I have a panel of two gentlemen with me in studio, and I will introduce them. And now I will start with the one who is seated to my immediate left, and his name is Dr. Enos Masini from the Ministry of Health. Welcome to the program.
Thank you, Sami.
Such a pleasure. And to the extreme left, I've got a gentleman known as Meli Kipsang. Now, Meli Kipsang works for the International Organization for Migration in the Direct Observation Therapy.
Direct Observation Therapy Clinic.
Absolutely, clinic.
Yes.
He works right there. And in a short while, they'll be helping us understand the relationship between migration and tuberculosis. But before we get there, let me come to you, Doctor, in terms of TB in this country. We've had this discussion for a very long time. But then again, we cannot escape from starting it with a very basic question. What is TB?
Thank you very much, Sami. Tuberculosis is an infectious disease caused by a germ that is spread through the air and mostly affects lungs, but it can affect many other parts of the body. Mm-hmm. The disease is spread when somebody who has the disease coughs or sneezes or talks and puts the germs in the air, and then you inhale the germs, and then they go to your lungs. Mm-hmm. The disease is not spread by things like sharing utensils or sharing food, stuff like that. But it is important to know that if you inhale in the germs, the immunity or the body defenses may protect you from the disease, mm-hmm. or the germs may overwhelm the disease and you actually develop what we call tuberculosis disease. So many people actually do carry the germs, but they do not have the disease. Mm-hmm. When you develop the disease, it manifests as you have a cough, usually lasting for 2 weeks and more, and you will produce something called sputum. It may have blood or mucus. You will have a chain in the chest. You will lose weight, and then you will feel generally sick. Now, the important thing about tuberculosis for us is that in this country, tuberculosis is the fourth largest killer. It's the fourth largest killer mm-hmm. in terms of the number of people it kills every year. It kills close to 15,000 people every year in this country.
In this country.
The sad thing is that tuberculosis is both preventable and curable. Mm-hmm. Now, some of the things that cause tuberculosis to spread, or the risk factors for tuberculosis, is HIV. Before the HIV epidemic in this country, tuberculosis was at a much lower level. But from 90s, when the HIV epidemic came up, the burden of tuberculosis really increased. Mm-hmm. And the other things really also people who live in poor urban settlements are at higher risk because of issues related to ventilation mm-hmm. Of the houses that they live in, but also things related to poor nutrition. So TB generally disproportionately affects the poor people. Mm-hmm. But it is important to know that we have made very good progress as a country in control of tuberculosis. Uh-huh. Yes.
The progress is there, and we'll be getting to that as we talk about how we are faring as a country in as far as dealing with TB is concerned. Meli, coming to you, what is the relationship between migration and tuberculosis?
Thank you very much, Sami. Before I talk about the relationship, I'd like to let the viewers know what IOM is or who IOM is. IOM is an international organization for migration, which is, has over 151 member states, and it has offices in over 100 countries. Our mission as a migration organization is to promote health, evidence-informed policies and holistic preventive and curative health programs that is beneficial, available, and accessible by vulnerable migrants and mobile populations. So migrants, most people think is just refugees, but we have migrants in categories of refugees and also formal migrants, whereby they want to move from one country to another for studies, for permanent stay, for visitations. So most of the migrants, when they're coming to Kenya, Kenya is like a transit country where migrants come in and they also get to other destinations. And before they come to Kenya, these people mostly are not screened for any disease of public health importance. And in our IOM setup, we have Migration Health Assessment Center, where we do health assessments before migrants migrate from Kenya to countries of destinations. And this is where we carry out screening investigations depending on the technical instructions of the resettlement countries, and mostly our screening tool is chest X-ray. People who have abnormal chest X-ray get to further testing of sputum, and this is where we are trying to rule out TB as a cause of the abnormal chest X-ray. TB is a communicable disease. These migrants are not supposed to migrate while they're having TB disease, because we are dedicated to safe migration. So such people diagnosed with TB must be treated first before they proceed with their migration process. Yes, that's where now TB and migrations come in terms of movement of these people from one location to another. Should be safe movement, whereby disease of public health importance, especially TB, have been treated or rather prevented. Treated or rather prevented.
Yes. Before I come to Daktari, let me stick to you, Meli.
Yes.
Over the years, we've had a TB conversation.
Yes.
And even the Dr. Masini can chip in on this one. Over the years, we've had conversations about TB.
Yeah.
Why is it that this year we're looking at the migration angle with a little more caution?
Kenya is among the 22 high-burden TB diseases, and in the National TB Program 2011-2015 strategic plan, migrants were identified as special populations. So in this year's theme of trying to find TB, treating TB, and working together in eliminating TB, we are also coming at an aspect of this migrant population who are vulnerable in the sense that their movement maybe increase their chances of TB transmission, their nutrition status, their vulnerability in terms of overcrowding might have exposed them to transmission of TB. So this is where we team up with the National TB Program in terms of having accessible services to screening of TB among the migrant population, offering TB diagnostics, because we run level 3 biosafety culture lab, and also offering TB treatment services to these migrants. So we are partnering with the National TB Program in terms of them supplying us the TB drugs, but we are responsible for prevention activities among the migrant TB treatment services to these migrants. So we are partnering with the National TB Program in terms of them supplying us the TB drugs, but we are responsible for prevention activities among the migrants, screening of these migrants and diagnosis of TB, and also treatment of TB. Yes.
Great. Daktari.
Yeah, I think, thank you, Sami, for that question. And just probably to answer that is that to say that so far the background is that we've made commendable gains in the last 10 years in control of tuberculosis. The Ministry of Health, through its various dispensaries, health centers, and hospitals, has treated close to 1.2 million Kenyans for tuberculosis for the last 10 years, and successfully treated 90% of them. That's about 1.1 million of them, averting close to 500,000 deaths by giving these interventions. But however, there is still some journey to go. To be able to end the TB epidemic, we have to take strong and bold steps, and most importantly, shed a spotlight on key population that TB affects. And we are currently doing what we call the Kenya National Tuberculosis Prevalence Survey to determine the burden of disease, but also to determine who among the population in Kenya are most affected by the disease, like people living with HIV, people living in poor urban settlements, but also even immigrants. And therefore, in the theme of the World TB Day, MULIKA TB, MALIZA TB, just means having special interventions for the key populations that are affected by disease in a bid or in an effort to come to end the disease. And the angle of immigrant health that comes in is that there is a variant of tuberculosis called drug-resistant tuberculosis. That means it cannot be treated by the ordinary drugs that we use. It has to use more expensive drugs, longer treatment, and the drugs are not very easy to take. They are very toxic. Now, there is a significant contribution of migrants to this disease and to the burden of this disease in Kenya. And the ministry has therefore worked closely with the IIM to therefore provide treatment for drug-resistant tuberculosis in places like Dadaab, together with the UNHCR. It therefore becomes important that we have interventions to look at these key people that are affected by the disease if we have to be able to move to the next stage of our fight and ending the tuberculosis epidemic. Yes.
Because as the both of you were answering that question, something occurred to my mind, and it is related to the burden of disease. You rightfully say that a survey is being conducted to identify that, but then again, from existing statistics, the situation as it is right now, what are some of the findings that are within the domain of the Ministry of Health?
Within the findings in the Ministry of the domain, like for example, in last year, close to 90,000 Kenyans were treated for tuberculosis across the whole country. That means they were tested, found the disease, and put on treatment. And close to 90% of them were successfully treated. But me and you know that not everyone who gets the disease is able to access health facilities and therefore be notified to us. They will be there for those people who actually have the disease but do not get to be treated, so-called the missing cases. And by doing the survey, we are able to determine these missing cases where they are. Because it's important for an infectious disease like tuberculosis that everyone who has disease accesses treatment much earlier. And once he's put on treatment, not only for his benefit that he gets cured of the disease, but he stops spreading the disease. So one of the things the survey will help us to find is those cases that we've not previously been finding, where are they? Then we develop strategies to find them. And then when we find them, we clearly put on them treatment much earlier. And then in effect, we'll therefore halt the spread of the disease. And our thinking mostly is that the remaining cases are probably in key affected populations. But the survey is really going to determine. But it's also going to determine which parts of the country have much more disease than the other. There are parts of the country where the disease is much more negligible. So you will have different interventions from those counties where it has a higher burden. So you will know where to put much more resources in, where to lobby, for example, county government, national government, health partner organizations to put much more resources to mop up any cases of tuberculosis.
Absolutely. Melly, coming to you. Migrants have been identified as a special population.
Correct.
That we cannot do away with if we're going to have a holistic conversation about tuberculosis in this country. After that was done, what measures, what steps have been taken to ensure that no one comes into the country with TB and no one leaves with TB into another country?
Thank you, Sami, for that question. When migrants get into our country, for whatever reason of their migration, it is the prerogative of IOM to do migration health assessment on these migrants and determine if they have contracted TB, and if they have contracted TB, they've got to be put on TB treatment. Just echoing the statistics that Dr. had mentioned about Dadaab refugee camp, which is the highly populated refugee camp in the country, is that we've been tackling multi-drug resistant TB treatment for over 200 patients between the year 2009 and 2015. And these are migrants who have been diagnosed with TB, which is resistant to the normal category 1 TB drugs in their home countries, especially Somalia, but they don't have existing systems for treatment. So such patients get access to a facility in Dadaab MDR ward, and they're registered and put on treatment, and treatment takes a minimum of 24 months to 48 months. So we have 4 screening facilities within IRM, both in the camps, Kakuma Refugee Camp and the Dadaab Refugee Camp, and we have also assessment center in Gigiri, and we have partnered with another agency in Isli to assist us in accessing population that might find Gigiri as not accessible to these services. So the screening of these migrants is very robust in terms of history taking, physical examination, investigative, diagnostic investigative procedures, so that we don't miss out on any migrant who might be harboring TB bacteria. Mm-hmm. And these people are immediately registered and started on TB treatment, and only proceed with migration after they've been declared cured. Mm-hmm. We thank the National TB Program for standing with us in terms of supplying us with multi-drug resistant TB drugs, giving us the tools, and registering even our facilities to become a fully fledged TB registered facility. Mm-hmm. Remember, we are not only dealing about migrants when it comes to TB services. Any Kenyan, any person within our catchment area can walk into our IOM TB treatment facilities to access our TB treatment, because TB treatment is free. Mm-hmm. Yes.
When it comes to our neighborhood,
yes,
I'm looking into Somalia, Tanzania, Uganda, South Sudan. Mm. We also got Ethiopia.
Yeah.
Along those borderlines, mm-hmm. Do you apply the same amount of caution across the board, or are some borderlines more notorious than others?
I will say there are borderlines that really are more porous to migrations, mm-hmm. in our country, especially the Kenya-Somali border, and that's where we have the highest burden of drug-resistant TB coming into our country, and now making us to respond in terms of attending to this caseload coming into our country. Mm-hmm. About Uganda, Tanzania, and Ethiopia, I will tell you also we have IOM offices operating in these countries, and they help in screening and also doing migration health assessment in these countries. So the burden from the other countries is less compared to the burden coming from Somalia.
Why Somalia? Why is the burden higher from Somalia?
We all know about the civil war that has been going on in Somalia, yes. whereby the government has not been able to run their fully fledged functions in Somalia. So health is very much affected, and in this aspect, the WHO has supplied rapid test kits called the Gene Experts to diagnose if someone has drug-resistant TB. They've had the privilege of having such diagnostic facilities, but now they don't have the capacity to treat. And this is whereby immediately these migrants are diagnosed in their home countries with multi-drug-resistant TB. They are immediately told, cross over to Kenya, where you can get access to drug-resistant TB drugs. Mm-hmm. And that's where we're generating a lot of cases coming from Somalia.
Right.
Yes.
Dr. Masini, let's lay bare the myth versus fact when it comes to knowledge on tuberculosis.
Thank you for that. And basically, as I've said earlier, tuberculosis is caused by a germ, and it's spread through the air. And that when you breathe in the bacteria, you get infected with the germ, and you can remain, your body can contain the germ or the infection without causing disease. But if for any one reason or another, your body defenses to disease, otherwise called immunity, go down, then the germ multiplies and flares up and becomes disease. Mm-hmm. That is the fact. Then the other aspect of the fact is that TB is both preventable and treatable. Now, the other myths that tuberculosis is caused by witchcraft, it's caused by sharing utensils with somebody who has it, that generally, fuel stigma and discrimination of patients who have the disease are not true. Also, the other myth that if you have tuberculosis, then you are HIV infected is not true. What is true is that if you have HIV, you have at a higher risk of developing tuberculosis. But it doesn't mean that if you have tuberculosis, then necessarily you have HIV. In fact, in this country, it's only 30% of all the patients of TB who actually have HIV. Who have HIV. Mm-hmm. But also just to speak about key things is that one is that we have made major steps in controlling tuberculosis that is attributable to HIV. And one of the things we've done is that previously, 5 or 6 years ago, close to 70% of all our TB patients in this country were actually HIV infected. That has reduced to about 30%. It's because we've done activities called TB-HIV collaborative activities. We test them for TB. People living with HIV, we test them for TB. People living with TB, we test them for HIV. But also we put all people who have HIV, we put a huge number of them on antiretroviral therapy. That boosts their immunity and stops them from developing tuberculosis. Starting from last year, we've moved to another level, is that we are providing a drug, one of the drugs used for treatment for tuberculosis, for 6 months for everyone living with HIV in this country, to be able to prevent them from developing tuberculosis. We target to put about 900,000 or so people living with HIV on this drug by the close of this year. We have so far put about 150,000 of them. Then secondly is that we are facing in new technology in testing for tuberculosis. Mm-hmm. Previously, tuberculosis could only be tested using a microscope that was actually discovered by a German physician called Koch in 1882. In fact, that's why March 24th is celebrates the day when he discovered that germ using that microscope.
Yes.
That has been the mainstay of testing for tuberculosis. But from 2 or 3 years ago, there's a new and better technology called GeneXpert that we use for testing tuberculosis. It's much more accurate. It gets more, it finds more people with tuberculosis, but it's also able to test for those who have drug-resistant tuberculosis. We have about 126 such equipment across the whole country. In fact, each county has about 2 of them. Now, with this technology, and if we expand and ensure that more people who require to be tested are accessing this new testing technology, then we will be able to find more people with the disease, find more people with the drug-resistant type of tuberculosis, and put them on treatment. But also importantly is that the ministry has increased the network in which people can access services. So you can go to basically any health center or dispensary near you, and you'll be both tested and treated for tuberculosis. But we've also worked with faith-based organizations and the private sector, just to ensure that the Mwananchi can be able to access these services much closer to them.
Right.
Both testing and treatment of tuberculosis has no charge to it. So that ensures that you do not again incur another extra test in having the test done or the treatment being given. Even for multi-drug resistant tuberculosis, which a treatment cost takes about close to 2 million Kenya shillings, is still provided free by the ministry. But we're also adopting in new drugs that are coming to the market to ensure that we can better treat drug-resistant tuberculosis in this country. But also to do this, we use a platform where, as you asked earlier, what data do we have? We collect data through an electronic method, right from the health facility to the national level, to know how many people have the disease, which parts of the country are having a higher burden of the disease. So in essence, despite all this progress, we still, as I've said, much more work to do. And in the theme of the World TB Day that will be celebrated next week, will be commemorated next week on 24th, is to actually now go down to which are these particular people or groups of people that we can shed more light on, that will be celebrated next week, will be commemorated next week on 24th, is to actually now go down to which are these particular people or groups of people that we can shed more light on, put more interventions on, and get the disease, which, as the prevalence survey that we are currently doing will show, where is the burden of tuberculosis more in this country, and how can we put more emphasis on. And as like my colleague from the International Organization of Migration has correctly stated, how can we work with neighboring countries in terms of cross-border health issues to be able to ensure that we control tuberculosis, especially drug-resistant tuberculosis, to stop from spreading to us.
Exactly.
Yep.
That note is what I'd like to transfer to you, Meli.
Okay.
Of course, when it comes to relationships amongst states, or actually it's among, because
Yes.
it's many, among states,
Yes.
there has to be a certain kind of protocol.
Yes.
Is there existing protocol that governs the relationship amongst states,
Yeah.
Kenya and others, when it comes to dealing with tuberculosis?
Yes, I will say there is an existing protocol whereby a country has the prerogative responsibility of ensuring that disease of public health importance doesn't spread from one area to another location. And this is done by, through the national health agencies, making sure that preventable communicable diseases are screened prior to migrants moving from one location to another. And again, in countries where we recognize that they have no such capacity of clearly screening and making sure that migrants don't move from one location to another with communicable diseases, this is where we talk through the National TB Program to talk with their counterparts in their existing countries. And through now the National TB Program, they are able to capacity build the countries where they are lacking in some diagnostics or even identification of cases, and even setting up structures on treating and preventing transmission of diseases from one location to another. And as Dr. Masidi said, the allocation of over 100 gene expert machines to assist us in early diagnosis of TB cases in Kenya should spread also to our neighboring countries to assist them in early detection of TB cases, because one untreated TB case is able to spread to up to 15 people in a year. So when we diagnose early, we also prevent transmission of this person to another 15 people, which increases now the mode of transmission to other people.
To other people.
Yes.
Dr. Masini, when you talk of TB being transmitted through the air, being airborne, talking of inhale and exhale, I could be suffering from TB. Let's look at the people around me, or even the caregivers. How are we able, to protect them from also getting the disease?
Thank you, Sami. I think the key to protection is to be able to find the people with tuberculosis much earlier and put them on treatment. Because once you've started on treatment, a few hours after that, you cannot spread the disease. And it's more about ensuring that there's awareness that if you have a cough, lasting for 2 weeks or more, please go and seek advice from your healthcare provider, so that you can be tested for tuberculosis, find out what you're suffering from, and you put on treatment. Equally, especially for people who are close contacts to you, especially children who are under 5 years, for them they carry a higher risk of contracting the disease. And what we do is that if you are found out to have a disease, we have to screen all the children who are in your household. And if they do not have the disease, we put them on the drug that I referred to earlier called isoniazid, one of the drugs used for treating tuberculosis, for a duration of 6 months to protect them from TB. And if they are found with TB, then they are put equally on treatment. So the important thing about prevention is to be able to ensure that there is early testing and early treatment, so that you can halt the spread of the disease. But it hinges more, therefore, on public awareness, and in such like you're providing here, where the public gets to know that indeed if you have a cough, you have night sweats, you're feeling generally unwell, please go and see your healthcare provider, so that you are tested and it's found out what you have and you put on treatment if you have tuberculosis. The key point is that tuberculosis is both treatable and preventable, and each one of us in whatever station we are in life, we can take action wherever it is. If you are in a public transport vehicle, you can ensure the windows are always open and there's fresh air circulating.
Exactly. The small things that go a long way in making a difference.
Correct.
Before I even cross over to Meli, which ones are they when it comes to MULIKA TB and MALIZA TB?
The key things, one, is to take responsibility for your health, to go for a check if you have any symptoms suggestive of TB that are referred to ensure that where you are, you ensure ventilation, keep the windows open, ensure there is flow there as much as it is possible. If you've been diagnosed with the disease, take the drugs as you've been prescribed for by your healthcare provider every day at the appointed time as it's been advised to you. Because if you don't, then the germs will not be cleared, or they will multiply again, and then you will be able to spread the disease, or you will be able to develop a more worse form of tuberculosis called the drug-resistant tuberculosis. Another issue is that if you know anyone who is coughing or has signs and symptoms suggestive of tuberculosis, you advise them and refer them to their nearest healthcare provider. Protection of children. Children are without a voice, and we have to be a voice for them. Is that if you know a child who is under 5 years and in contact with someone who has tuberculosis, it's important that that child is screened for tuberculosis, and if they don't have the disease, we can be able to put them on a drug that will protect them from tuberculosis. So key is that, as you've rightfully put, that each one of us can play a small part in our everyday life to ensure that we control tuberculosis in this country.
Tuberculosis. Millie, when it comes to the scope of work you do, what are the main challenges you face?
As I told you, migrants were labeled as special group, and with this special group come special challenges altogether. This TB treatment we are offering, the drugs have some also side effects, and this aspect it hinges also on the nutritional status of this person. So tolerability of TB medicines also needs an improved nutritional status of this patient. And this population, mostly, they have challenges with nutrition. And this becomes now challenging in terms of the person is diagnosed with TB, has TB bug, needs to be put on TB treatment, but also nutritionally, this person is not that stable. So to counter that, we've been having a nutritional program to support patients on TB treatment. Apart from the food rations they're getting in the camps, we've been supplementing nutrition to them for them to tolerate the medicines and also to improve the cure rate of these patients with TB. We have also urban migrants who are not in the refugee camps, and when they are diagnosed with TB, there are support structures for them in terms of coming to a facility for treatment every day, because our model we use is directly observed therapy, where a patient comes to a facility every single day, and the healthcare worker administers TB treatment and records the TB treatment. So the challenges with them is having the transport cost coming to a facility every day. We've made it easy, and Dr. mentioned that TB is treatable, it's curable, and it's also free. Drugs are free. And we offer free diagnostic tests at IOM and even follow-up tests in terms of X-ray, sputum collection, and baseline blood tests. So we've eased the burden of them incurring more cost in terms of continuous investigation, but just reducing it to them having that ability to come and get treatment in our facility. And as I told you earlier, to just increase our accessibility, we were not, we did not restrict ourselves only to Gigiri, but we had to partner with another agency in Isli, where the catchment population is so high for them to access our facility freely every single day, and for them to benefit from this treatment.
Benefit from this treatment.
Yes.
Dr. Masini, when you talk of drug-resistant TB, how are we dealing with that as a country?
For the past 5 years or so, we've treated close to 1,500 Kenyans with drug-resistant tuberculosis. And the good thing is that we've treated 80% of them successfully, and making probably our success rate in treating this difficult variant of TB fairly commendable. As I mentioned earlier, drug-resistant tuberculosis is actually man-made. It's caused by when either patients abscond on treatment. You are on treatment for the ordinary tuberculosis, you don't take drugs as prescribed, and therefore the germs multiply, and then they change into variation that is drug-resistant. So the essence there is prevention, where you are able to take drugs as you are prescribed for by your healthcare provider, but also on our part as government to ensure that the drugs we give are of good quality, and that one we do. But in terms of other measures that we've done is to provide testing for drug-resistant tuberculosis. Right now, we can be able to test for drug-resistant tuberculosis in all the counties across the country. Then secondly is that we are able to provide treatment at the facility nearest you. Previously, a few years ago, we would only have treatment at the major hospitals, like at Kenyatta National Hospital, Moi Teaching Referral Hospital. Right now, we can be able to, if you are found to have the disease, we will be able to support the healthcare provider in the dispensary next to you to be able to provide you treatment from the comfort of your home. Then, fourthly, is that we are also putting in new drugs. There are newer drugs that are coming on the market to be able to make the treatment of drug-resistant tuberculosis much better. Usually the treatment takes 20 months compared to these other tuberculosis which takes 6 months.
6 months.
It's much, much more expensive. So the essence therefore lies in preventing the disease rather than taking care of it. Yes. Absolutely.
Your final word on this discussion, Meli.
Okay. Before I give you the final word, I just want to highlight one of the challenges that we also face in our TB treatment for migrants. Migrants come in families. Let's say, for example, a family size 10, family consisting of 10 family members. And when one family member is diagnosed with TB, it means the 9 of the family members cannot proceed with migration until this one patient is cleared and treated and cured. So this becomes a challenging situation for the whole family in terms of they've been waiting for migration process to continue from a refugee camp. And when they've had the chance, one family member has been diagnosed with TB. So there's a lot of psychosocial support that we offer to this family to understand that this diagnosis and treatment is beneficial not only to this patient alone, but also to family members. Because when one patient is not treated, the other family members in close proximity with this patient are also exposed. So we offer psychosocial counseling for these family members to understand the importance of having TB treatment, doing contact evaluation for the family so that they can all migrate safely to their country of destination. My final word in this program about TB awareness is that, please, we have right now facilities all over this country offering TB services. If anyone has any cough or suspects to be having any signs of TB, it doesn't cost a thing to visit a facility for just a healthcare worker to take history on you, do some examination or even investigations, because the diagnostics treatment is free. And I want to tell you that TB is treatable, TB is curable, and TB drugs are free. So we have a role as every other citizen to just take that step to prevent TB. Let's all find TB, let's treat TB, let's work together in eradicating TB. MULIKA TB, MALIZA TB.
MULIKA TB, MALIZA TB.
Correct.
Dr. Enos Masini, your final word, and as you give it, kindly tie it in with how we are faring in terms of public awareness on this disease is concerned.
Thank you. 3 key messages for me,
yes,
and all of them hinge on public awareness, really. One is that TB is treatable, so that if you have a cough that's been lasting for more than 2 weeks, you have chest pain, you have lost your weight, you've been in contact with someone with tuberculosis, go to your nearest healthcare provider, you'll be tested for tuberculosis. And when you are prescribed for, if you're found to have TB and you're prescribed for drugs, take them as has been prescribed by your healthcare provider, and you will be cured. Then secondly, it hinges on prevention. TB is also preventable. And the issue about prevention is more related to what you said about public awareness, is that if you have the symptoms or signs that I've said about tuberculosis, please go to your healthcare provider early enough for treatment. That if you're put on treatment, you will not spread the disease, and therefore you will help. The treatment of tuberculosis serves 2 purposes. It helps you cure the disease, but it also serves to that once you're cured or your disease is managed, you will not spread it to your family members, to your one. You will help. The treatment of tuberculosis serves 2 purposes. It helps you cure the disease, but it also serves to that once you're cured or your disease is managed, you will not spread it to your family members, to your wife, your spouse, or to your children. Then the other issue about prevention that is key is that, and we would like really to, as part of public awareness, that if you are living with HIV, as you go to your healthcare provider,
Yes.
we now have a drug called isoniazid that's provided for a duration of 6 months that will protect you from developing tuberculosis. Ask your healthcare provider about this. If you have a child under 5 years who's in contact with anyone with tuberculosis, please visit a healthcare provider. We will also use the same drug for a duration of 6 months to protect the child from tuberculosis. The last message is about the survey we are doing called the Kenya Tuberculosis Prevalence Survey. This is the first survey being done to determine the burden of tuberculosis since independence. The last one was done in the colonial area in 1957. We planned to reach 72,000 people, to screen them using chest X-ray, and to be able to ask them to produce sputum for testing in the laboratory. We've just done about halfway. We've reached about 36,000 of them. We still have some more counties to go. And when we come to your county or where you are, please allow us to be able to screen you. Come to the near, we'll have a mobile field site. That means where there's the chest X-ray site and the clinic. Please avail yourselves there so that you can be able to be X-rayed and we'll be able to produce sputum. If you're found to have the disease, we'll provide with you treatment at that. But also the results, you are contributing to gaining knowledge that will assist in planning for ending tuberculosis in this country. Yes.
Dr. Enos Masini, thank you so much. From the Ministry of Health, thank you so much for coming through and for sharing your insight on this matter. Meli Kipsang from the TB Direct Observation Therapy Clinic. I got that right, huh?
Correct.
Absolutely. Thank
Pleasure.
you so much for coming through.
Pleasure.
And of course, this is a conversation that goes on way beyond March 24th, but of course that is a period dedicated towards highlighting tuberculosis, its challenges, its issues, and of course we narrowed down with the situation right here in the country. Thank you for watching. My name is Samuel Njoroge. Good Morning Kenya continues. Safina Cheng is up next, so please do not go anywhere. Give us the opportunity to kickstart your day.